All right, here we go. It is Monday. It's week 5. It is endocrinology. We're going to talk about, well, in this part, tomorrow we'll talk about adrenal crisis, but we're mainly talking about adrenal insufficiency. So, adrenal insufficiency, that was the big controversy. Did Kennedy have Addison's disease? Is always the theory, so who knows. But adrenal insufficiency, also called hypoadrenalism, it was first caught on to or described in literature by of course, Addison back in the 1800s, and this discovery of this syndrome was considered the birth of endocrinology. And what is the definition of adrenal insufficiency? It's a failure of all, or at least part of the adrenal cortex to not produce its hormones. And we all know those hormones. We went over those a million times. We have the mineralocorticoids, glucocorticoids, and the adrenal androgen, i.e. aldosterone, cortisol, and DHEA. And yeah, this is no joke, especially Addison's disease, because it can take out your entire adrenal cortex where you're not getting any hormones coming out, and it can kill you. And that's called the Addisonian crisis, which we'll talk about in tomorrow's lecture. But it is potentially life-threatening because you need glucocorticoids and mineralocorticoids for life, right? No adrenal steroids will send you into hypovolemic shock, make you become hyperkalemic, and or put you into hypoglycemic shock. So all of these can kill you. All three of them in and of itself. Death will occur in 3 to 14 days if you don't have any cortisol. You need cortisol to stay alive. Flashback, hypovolemic shock we talked about in CVPP, but just recall it's the loss of intravascular volume. So basically it's a loss of blood fluid, which typically results in hypotension. But there's several ways you can lose blood fluid. You can lose it into the interstitium. If the microcirculation is too leaky, it can leak into the interstitium. It can be caused from dehydration, from, for example, chronic diarrhea, or from hemorrhage. That's actually hemorrhagic shock, which is a subcategory of hypovolemic shock. And maybe your heart just isn't powerful enough to pump blood out. That's called cardiogenic shock, which is a subcategory of hypovolemic shock as well. So the bottom line with any of these mechanisms, you're not going to have enough oxygen. The tissue's not going to, the bottom line is the tissue is not going to be perfused. What's that mean, perfused? It means that you're not going to have enough oxygen in your tissue to feed the cells, and cells will start to die. All right, what's the prevalence of adrenal insufficiency? There's two kinds, right? So this is kind of just general. It's between 0.01 and 0.02% of the population, so it's rare. Secondary adrenal insufficiency, a little bit more common, as we'll see, but yeah. Interestingly, the prevalence of this condition has been getting worse because of the widespread use of glucocorticoids, right? The baby boomers are here, and the baby boomers have more aches and pains and chronic inflammatory diseases, and so more and more exogenous glucocorticoids are being prescribed. I have to say exogenous. So do you know what that means? Exogenous. It's not really, you shouldn't say it exogenous, it's exogenous. That means something artificial that you're taking by mouth or getting an injection of. So exogenous, because cortisol is an endogenous glucocorticoid. So make sure you know the difference between endogenous and exogenous glucocorticoids. All right, and yeah, so exogenous, we talked about how endogenous glucocorticoids can shut down the pituitary. Well, exogenous glucocorticoids can do the same thing, and we'll look at that more specifically in a minute. There's two flavors or two subcategories of adrenal insufficiency. Primary adrenal insufficiency, secondary adrenal insufficiency. Let's talk about primary adrenal insufficiency. So this is Addison's disease. It's commonly known as Addison's disease. Sometimes it's called primary hypoadrenalism. They're not going to say that on boards because that tells you the problem. You're not making the adrenal steroids is the problem. Prevalence is about 0.01%. This one, I remember Addison's, there's these 3 A's. Addison's disease is caused by an autoimmune attack of the adrenal cortex, right? So that is the problem with Addison's disease. Usually, I mean, it's not 100%, but it's usually an autoimmune attack. So therefore, if you get an well, we'll look at who gets attacked here in a second. But therefore, the cortisol, aldosterone, and even DHEA may get completely wiped out. Usually not DHEA though, as we'll see here in a second. So the typically caused by an autoimmune attack, as I said, but not always. An infection can also take out the adrenal gland, the entire adrenal gland. So I see here, a disease is caused by a disease, pathology, or injury. That would be the infection. Disease would be the autoimmune of the adrenal cortex, and it's usually caused by autoimmune disease. All right, so autoimmune disease related Addison's disease. Again, 85% of the time in developed nations, this is the cause of Addison's disease. And sometimes it's called autoimmune adrenal insufficiency. They're not going to say that, it gives it away. So Addison's, I always think Addison's disease, adrenal cortex injury, autoimmune related, because that's the most common cause. So who is the target of the autoimmune attack? Well, it's the enzyme I've been talking about over and over again. It's 21 hydroxylase, which has many AKAs. CYP21, steroid 21 monooxygenase, 21 alpha hydroxylase, P450, 21A2. The only ones I remember for myself is 21 hydroxylase. I do know CYP21. Those are probably the two most common. So 90% of the time the autoimmune attack is against that. And remember, that is the gene needed to make both aldosterone and cortisol. Right? So in the most common form of Addison's disease, the patients will have normal expression of the adrenal androgens, or DHEA, whichever the board question will say. They might say adrenal androgens. It's easier than spelling out DHEA. But yeah, DHEA is typically spared in the autoimmune attack. Remember this, which we've looked at a million times, how cholesterol turned into pregnenolone, which is converted into progesterone. Progesterone is converted ultimately into aldosterone and cortisol, but you need 21 hydroxylase at these steps to make this occur. So that is important. What about antibody testing? Is there a test that we can do? Well, for children, the answer is yes. But for children, there is a blood serum test, an antibody test. You can look for this 21 hydroxylase autoantibody. In children, it is incredibly accurate. About 100% of children who test positive for this antibody actually have this autoimmune disease related Addison's disease. Adults, it doesn't work that good. It's only about 50% accurate. So it has a very large false positive rate. In other words, its specificity is crummy. Concomitant disease. So if it's an autoimmune disease causing it, the patients tend to have other autoimmune diseases. Like 50% of Addison's patients will have at least one of these. Hypothyroidism, type 1 diabetes, vitiligo, rheumatoid arthritis, pernicious anemia. So it is related, and that makes sense. You see that in all the autoimmune diseases. If you have one, chances of having another are high. What about non-autoimmune causes? There are other causes. Remember we said was 80%, but there are other causes. And these causes aren't good, like tuberculosis. It takes out the entire adrenal gland if it gets that far. So the adrenal androgens can also be deficient, which means lacking. And recall that Addison's disease, only the mineralocorticoids and the glucocorticoids are affected. So in third world countries, the most common cause of this is tuberculosis adrenalitis, which is still an Addison's disease, but it's not caused by an autoimmune attack. It's caused by the tuberculosis bacteria. And so worldwide, it's still the most common, but in developed nations, it's autoimmune. And that TB bug, for whatever reason, it loves the adrenal gland. There are other causes too. AIDS, the AIDS virus, likes to hit the adrenal cortex as well. Histoplasmosis likes the adrenal gland. Cytomegalovirus virus likes the adrenal gland. It just loves to burrow in there and cause an inflammation and infection. And then there's some of the cancers and other problems. So metastatic disease from the breast and lung, it also 70% of the time it can hit the adrenal gland. So maybe one of the first signs of metastatic breast carcinoma is Addisonian symptoms. And embolisms can get stuck in the vasculature that goes to the adrenal gland, and you can get ischemia and tissue death. If you get tissue death in the cortex of the adrenal gland, well, there goes your adrenal gland. What about the blood findings? And we're going to get into this more next time as well, but just the primary adrenal insufficiency. What are the blood work findings? Well, if you see, that's why I went so in detail over the functions of the adrenal steroids, or of the adrenal steroids, so you'll understand what the findings are. If you're not releasing cortisol and ADH, what do you think cortisol and aldosterone, what do you think the findings will be? Well, you'll have hypercortisolism, you'll have problems with blood sugar, you'll have decreased aldosterone, so you won't be able to suck salt and water back into the body, so you'll get a hypotension. You'll get signs of hypoaldosteronism. And the big take-home message for this slide is you're going to get huge levels of ACTH secreted, because there's nothing wrong with be careful with this, the HP axis. Hypothalamic pituitary axis is fine. There's nobody messing with that. So if cortisol isn't shutting off this HP axis, your CRH is going to stimulate the corticotrophs cells to release tons of ACTH. So you'll have very high levels, highest possible levels of ACTH. And then remember we talked about that ACTH can get into the skin and be converted by PC2 into alpha MSH. And alpha MSH overstimulates the melanocytes to make really dark areas of skin. So you get this is an Addisonian patient. Then you get this blotchy face look. And this confused with melasma sometimes in other conditions we'll talk about in 7th quarter. But yeah, yet when you test their adrenal androgen levels, they'll be normal. Okay. All right, let's go to secondary adrenal insufficiency. So these slides are completely different from last quarters because I'm just putting this section in and it's kind of a mess, so I tried to redo it, so bear with me here. So secondary adrenal insufficiency. So the problem now is ACTH is not being released. That's the bottom line. Now there's a bunch of causes for this, but the bottom line is ACTH isn't being released. That's not the problem with primary, right? Primary adrenal insufficiency, there's no problem with ACTH. The HP axis is fine. This is a problem with the HP. At least the origin of the problem is with the HP axis. So why isn't ACTH being released? By far, the most common cause is the exogenous use of glucocorticoids. One of the most common is prednisone. And you'll remember that word if you don't know that, because GPs love to prescribe that for patients with sciatica. And does it work? It's controversial if it works or not. It never worked for me at all. Helped my knees though. But there are some other glucocorticoids, hydrocortisone, dexamethasone. These are the big three that you'll run into. What's the prevalence of secondary adrenal insufficiency? It's twice that of Addison's disease, but it's still rare, 0.02%. Why do you take prednisone? Why would someone take prednisone anyway? Well, it's very powerful. Remember the anti-inflammatory cascade? I won't go over that again. But prednisone snips it way up at the top of the cascade. And therefore, it's a very powerful anti-inflammatory. So it's used for inflammatory conditions, which are autoimmune related. You can have inflammation from autoimmune attack, or an injured tissue can cause an inflammation, or bug, like an infection, staph can get in there and cause an inflammation. And usually problems with the respiratory, gastrointestinal, musculoskeletal, and dermatological systems is the reason you take exogenous glucocorticoids. There's other forms of exogenous glucocorticoids. They can be inhaled. I mean, the ones where prednisone, we're talking about oral. Those are taken as a pill, but you can inhale them. Some asthmatics need to use an inhaler 3 or 4 times a week when it's really bad. And that's a steroid, and that can do the same thing, shut off your HP axis. Topical steroids, those are for skin conditions. Intraarticular steroid injections, so Depomedrol injected into the knee or into the facet joint. Ocular, so there's steroids that are made to put into the eye, drops, and the ears as well. And there's rectal corticosteroids for hemorrhoids, and progesterone therapy for breast cancer patients, and these are all steroids. So it's not just prednisone. How does the long-term use of exogenous glucocorticoids cause trouble? Well, we already talked about in depth the double negative feedback system of cortisol. How cortisol combine, it can turn around when blood cortisol levels get high enough, it can bind to the parvocellular neurons that make CRH and shut off CRH. You have to have CRH from the hypothalamus, paraventricular region of the hypothalamus, to make ACTH, right? And it can also bind to corticotroph cells directly, so it's a double shut-off mechanism. It's very powerful. Well, these exogenous glucocorticoids, which I'm going to abbreviate EGCs, not to be confused with ECGs, EGCs, exogenous glucocorticoids, they're a glucocorticoid, and they can also bind to parvocellular neurons and corticotroph cells and shut them off. And that's exactly what they do if you're on them for more than about 4 days or so. Remember this? Cortisol or the exogenous glucocorticoids, they can bind to parvocellular neurons, shut off, say goodbye to CRH. And they can bind to corticotroph cells, shut off the production of POMC, which is immediately converted into ACTH. Right? Oh my God, so no ACTH, no DHEA. Are you going to die? You're going to die, right, without ACTH. Well, you're not going to die because, well, yes, you are. Your brain, I hear some of you arguing with me. If you don't have ACTH, you can't make cortisol and you're going to die. No, you're not going to die because you're taking a form of cortisol. You're taking an exogenous glucocorticoid like prednisone. It can bind to cortisol's receptors. So you'll still have plenty of blood sugar around, but here's the key. Most of the time, everything will be okay most of the time. And we'll see what I mean by that in a second. So ECG, the exogenous glucocorticoids, will do the job of cortisol, sort of, most of the time. If you're on a 10-day course of prednisone, I mean, we're not really talking about you people. We're talking about people who are on this for months and months and years because of inflammatory conditions. Although I'll show you a study where it kind of shakes that line of thinking a bit. You also won't have much adrenal androgen around. DHEA won't be around. But that doesn't have any life-threatening effects, so it's really thought to be not that big of a deal. Now, why did you say, it sort of takes the place of cortisol, these exogenous glucocorticoids? Well, the problem is if you, the natural thyroid or the natural adrenal gland, it is constantly changing the amount of cortisol that is being released, dependent on how stressed you are. The more stress you have, the more cortisol is released. And if you're really at peace and you're not, doing anything, then you don't need very much. I think the average is about 7.5 milligrams of cortisol is your average kind of basal level, normal run-of-the-mill secretion of cortisol. Your average therapeutic dose of prednisone is more like 30, 40 milligrams. So see, you're going way over physiological dose for things like that. But prednisone courses for musculoskeletal are very short. But anyway, so you're not going to die. You have cortisol. You have exogenous glucocorticoids take the place of cortisol. What if a huge stress comes in your life? And we'll look at these more tomorrow. But what if you break your femur? What if you have a heart attack? What if you get symptomatic SARS-CoV-2 virus and get COVID-19 disease and you're in intensive care? That is some major stress, and your adrenal glands will be way above these levels. And now you see the trouble? If you're only on 40 milligrams and you need 100 milligrams, where's that 60 milligrams going to come from? It ain't going to come from anywhere. And so, as you learn from biochemistry, stress soaks up glucose out of the blood like crazy. And how do you replenish glucose? I mean, you can't be eating all the time. Where does it come from? Cortisol. Cortisol breaks down, and we'll look at this in depth, I think, tomorrow. Or at least soon we'll do a little biochemistry. But cortisol can get sugar and by breaking down, for example, breaking down protein, breaking down muscles to release amino acids, which can be run through the Krebs cycle, which can be run through gluconeogenesis, and we'll look at that path. So you're not going to have this. So you're going to have low blood sugar, and you could go into hypoglycemic shock because of this if you happen to be on a set dose of glucocorticoids. So everything I said. So what's the solution? Well, people who take prolonged glucocorticoids, exogenous glucocorticoids, know if they have a big stressor coming, or if they have to take more. If they start feeling lightheaded and hypoglycemic, they have to take more, and it's very, very difficult to learn how to control it, and it can take years to figure it out, and it's just sometimes you can't figure it out. So it's significant morbidity for people who have to be on these artificial exogenous glucocorticoids. What's another problem with exogenous glucocorticoid therapy? What happens when it's time to come off? Let's say you've had a really bad tendinitis and the doc puts you on prednisone and you've been on it for 6 months. What happens when you come off? Well, sometimes the HPA axis never starts up again because we just said with a double negative feedback system, you shut down the hypothalamus, you've shut down part of the anterior pituitary, the corticotroph cells, and you've also shut off the adrenal glands because they're not working, or at least the zona fasciculata and reticularis aren't working. Remember, the zona glomerulosus is not affected by ACTH much, maybe a couple percent. So that'll be fine. Aldosterone will be fine, but the rest won't be fine. And so sometimes it never wakes up, and you're stuck taking replacement tablets forever. So that brings us to this very interesting Joseph systematic review of 2016, published in a very high impact journal, which 5.2 is in a specialty journal is pretty high. That's definitely a good top-notch journal. For example, the journal Spine is only, I think, 3 or 4 of these impact factors, and that's one of the top spine journals. So they studied 73 high-quality randomized controlled trials, and they pooled 3,100 patients together, 3,166 to be exact. I'm sorry, they weren't, the trouble with it, there weren't a super bunch of high-quality studies, though, but they put the best studies that they could find. And the average, most of the patients who were in these studies had been on exogenous glucocorticoid therapy for at least 12 months. Not everybody, though. There were some people who were only on it for 4 days, some 10 days. Some have been on it for 10 years. So they basically studied what happened to these patients when they tried to come off glucocorticoids, or exogenous glucocorticoids. So it turns out 15% of the patients, when they tried to come off the glucocorticoids, they still struggled with secondary adrenal insufficiency 3 years after their attempt to come off. So that's a big number. So secondary adrenal insufficiency is a huge problem with people who take prednisone for long periods of time. It can be tough to come off for some people. Now this study differs a little bit, but another kind of finding in the study was they found no dose correlations. Some patients were on even less than 5 milligrams, 2.5 milligrams per day, just a little supplemental dose. Now other studies haven't found the same. Other studies have found the higher the dose. That makes more sense. The higher the dose, the harder it is to come off. But this study didn't show that. So let's see. What about the evidence if you're a histologist and you took a biopsy of the hypothalamus and anterior pituitary, adrenal cortex? What would you see? There's actually visible atrophy. Sometimes within 30 days this atrophy occurs. Just showing that old saying, if you don't use it, you lose it, applies to the HPA axis. So specifically they found atrophy in the paraventricular nuclei, which is where parvocellular neurons. They found atrophy in the anterior pituitary. They found atrophy in the adrenal cortex as well, which makes sense. And finally, a warning. When you're on glucocorticoids for 10 days or more, make sure you taper the dose, because although some people can handle it, heaven forbid, if you're 2 days from stopping your glucocorticoids and you fracture your femur or you have a heart attack or something, you can go into hypoglycemic shock. So you really do need to taper. As you taper the dose, it lets your HPA axis kind of wake up and start working again. So be very careful with that. You'll have patients. Matter of fact, a couple weeks ago, I had a patient when I was doing my consultation service. I always ask medications, and they were on a 20-day course of prednisone at 40 milligrams, and they stopped cold turkey, and they didn't feel good for a couple days. They were getting really lightheaded, and I said, "Well, didn't they tell you you have to taper?" And no, they didn't tell me to taper, and so for whatever reason they didn't know, and they're lucky no big stressful event occurred. They could have been in trouble. Yeah, so everything I said, you could get a fatal drop in blood sugar if you have some huge stressor because your HPA axis is not working. So always taper. How about a couple more causes of secondary hypoadrenalism. So there are gene mutations. These are really rare, but you can have a gene mutation in the gene that makes POMC. Remember, that's the pro-hormone. That's the pre-ACTH molecule. So if you have a gene mutation in there, you can't make ACTH. You'll probably find out real quick when you're a baby on that one if you make it. There's the genes, the POMC gene. There's a SOC3 and PROP. SOC3, we actually talked about that in embryology. But there is a PROP1 gene as well. How about some more causes? Another common cause is people with tumors in their anterior pituitary, and they go in, and Cushing's disease, and they take out the tumor, and it injures the corticotroph cells, and they stop working. So you can get an inflammation after surgery, and that can induce a secondary hypoadrenalism. You can get cancer to the pituitary gland, which destroys the gland and the corticotroph cells to the point you can't make ACTH. You can get a pituitary tumor that damages the corticotroph cells as well. You could get a central nervous system infection that invades the pituitary gland itself. Head trauma, anything that damages the pituitary gland, sarcoidosis rarely. These are super rare things here. All right, that's enough for today. We'll pick it up next time on some of the clinical features, which you probably have a pretty good idea what they are. See you later.